To start out our sonographic evaluation, I'm going to place the transducer in a long axis orientation to the muscle of the infraspinatus tendon with the orientation marker angled towards the anterior surface of the patient's body. So as I slide the transducer slightly anterior, we'll pick out the anatomic landmarks. But first, I should optimize my image by moving the focal zones down to my area of interest, adding just a little bit of depth so I can see my bone landmarks. And now I have all the areas of interest for evaluation. And I always like to start out with pointing out the hard tissue landmarks, which are going to be the glenoid, which sits right down over here. This is the actual joint space, the glenohumeral joint space. This is the curved structure of the humeral head. The hypoechoic structure in close proximity to the humeral head and following the contour of the humeral head is the articular cartilage. Sitting superficial to that is the myotendinous structure of the infraspinatus tendon in long axis, and we'll look at the posterior deltoid and the subcutaneous tissue. So now I'm going to ask my patient, while the transducer is placed in long axis, to externally rotate the arm, and we'll watch the infraspinatus tendon muscle draw back and have her bring the arm forward again so we can see the contraction and extension of the infraspinatus tendon. Bringing the arm back and holding it in the position on the front of the body, I'm going to simply slide the transducer inferiorly, and I'm going to leave the infraspinatus tendon muscle and run right into the teres minor, infraspinatus, right into the teres minor muscle structure. Now, sliding the transducer slightly posteriorly, I'm going to adjust my frequency down one so I can penetrate just a little bit deeper. You'll notice that my frequency changed up on the screen up here from 9. I was at 12, it highlighted, I went down to 9 to give myself a little bit more penetration. Now, again, looking at the bone landmarks of the glenoid, the humeral head, the articular cartilage. Now what we're going to see is the wedge-shaped hyperechoic projection or view of the posterior superior glenoid labrum as it attaches to the glenoid and is between the humeral head and the glenoid. Now, in a second, I'm going to ask my patient to externally rotate, and what you're going to watch is that humeral head will roll back, and you're going to see some redundancy or the capsule fold back over the top of the glenoid. Watch at this point right here as I ask the patient to roll the arm back. The capsule folds over the top and then brings their arm back forward again. Capsule straightens back out, and once again we can see the labrum. One more time. Comes back, capsule folds over the top, and we bring that arm back into the neutral position. Now, once we've evaluated the posterior superior glenoid labrum, and this is not common in all labs, but it can be seen by ultrasound in most patients. The next structure that we want to evaluate is going to be the short axis of the teres minor and the infraspinatus. By turning the transducer orientation marker to a superior aspect, we can now see the scapula, and we're going to see the teres minor muscle belly and the myotendinous junction of the infraspinatus muscle belly. We can compare the echogenicity to look for fatty infiltration. Rotating the transducer back so the orientation marker is pointed out to the patient's anatomy right. We're going to go back to the humeral head. We'll see the glenoid and the humeral head, the posterior superior glenoid labrum. Now, I'm going to slide my transducer slightly medial, and turn the orientation marker slightly down towards the floor. And now I'm going to be viewing the spinal glenoid notch or saddle. Now, once again, I'm going to ask the patient to externally rotate their arm, and we're going to see a large vein dilate and bring the arm back to the front. And once again, bring the arm back, and we can see the vein dilate and bring it to the front. At this part, we're always looking for any type of paralabral cyst or ganglion at that point. Now, after we've completed that, I'm going to move the transducer superiorly until I get right on top of the spine of the scapula. So now the orientation marker is pointing to the patient's anatomic right. So this is going to be anterior this way. This is going to be medial on this side. So once I've got the transducer sitting just on top of the spine of the scapula, I slide the transducer slightly superiorly, and I fall right down into the suprascapular notch, which sits right at this point down here. For injection purposes, if we wanted to inject this area, you could bring the needle in from the medial aspect all the way down to this area right here.